Hello and welcome to my presentation on oculopharyngeal muscular dystrophy, otherwise referred to as OPMD throughout this presentation. The purpose of this presentation is to investigate how OPMD affects the speech and swallowing mechanisms. It is also our goal to identify the role SLPs play in assessing and treating patients with OPMD in the acute care model setting. I reviewed and evaluated the literature available to aid our knowledge in the SLP's role of caring for patients with this condition. Results found were that participants with OPMD present with visual impairments alongside speech and swallowing deficits due to a lack of intraoral strength and pharyngeal muscle weakness. The conclusion of this presentation is that impairments are often associated with OPMD directly relate to our scope of practice as SLPs. Therefore, farther research should be conducted to determine how to best serve these patients and their related deficits. Oculopharyngeal muscular dystrophy is a progressive congenital myopathy that is prevalent among 1 in every 100,000 people. The literature found that New Mexico actually has the highest number of OPMD patients, and it is typically found in those of French and Canadian descent. The condition occurs through a mutation of the PAB-PN1 gene. This gene abnormality has an excess of alanines that are known to deteriorate the cell and cause muscle weakness in the affected areas. The age of onset of OPMD is typically around 40 to 60 years of age, and the symptoms that present in the condition include ptosis or droopy eyelids, pharyngeal weakness, tongue atrophy, facial muscle weakness, weakness in the proximal and limb girdle muscles, and depression and delirium have been found in some cases. The first journal article I found that I thought would be important to share covers the swallowing characteristics in patients with OPMD. The purpose of the article was to evaluate how oral weakness affects the swallowing mechanism, weight, and quality of life of individuals with OPMD. And the swallowing functions in this study evaluated intraoral pressure, tongue endurance, a timed water swallow, quality of life questionnaire, and weight and height. And the result of this study found that oral weakness affected the swallowing mechanism, and quality of life in participants with OPMD was more than the control group. And tongue endurance did not greatly differ between groups. So the conclusion is that while weight and endurance did not appear to be impacted, muscle fiber loss seemed to present a role in why OPMD patients showed reductions in swallowing capabilities and patient ratings of their overall quality of life. The next article I reviewed is actually written by the same authors and researchers as the previous article. This article was written 5 years later in 2015, and this article covered the muscle weakness and speech characteristics in OPMD. So this study had 12 individuals with OPMD and 12 age-matched individuals to serve as the control group. And the purpose was to assess the similarities and differences between both groups by their speech and voice characteristics. And they assessed the following items below in their study. The results concluded that tongue strength was considerably weaker in the OPMD group, along with slower diadokinetic rates. But there was little variability actually in speech and voice tasks. So the conclusion of this article is that swallowing presents more limitations to those with OPMD than speech impairments due to tongue strength and muscle weakness. The article, though, did also conclude that treatment considerations should still be made to those who present with articulatory or speech-related deficits who have OPMD. I thought it was important to include this piece of literature because it focuses on the patient experience rather than on the swallowing and speech characteristics associated with OPMD. This study found that all participants suffered both physiological and psychosocial burdens associated with OPMD. The themes of these struggles included adjusting to change, managing misconceptions, seeking normality, facing the future, and informing their children of their condition. The conclusion of this article stated that those who work with these patients in the healthcare setting need to consider treating the whole patient and counsel them on how to manage their physiological and psychosocial burdens that often accompany living with OPMD. Although this gene abnormality is present at birth, it does not present problematic symptoms until the typical age of onset. During this time, the synapses are slowed due to the gene alteration. This demyelination of cells slows the connections and appears as weak muscle movement. It is important in the acute care setting to continuously monitor these structures and their functions in order to make the most clinically informed decisions possible for the patient. Because OPMD directly affects the strength of the oral, facial, and tongue muscles, strength, swallowing pressure, capacity, volume, and time will all be impacted in this OPMD patient. Pooling of saliva can also occur, which can lead to a wet vocal quality. Dysphagia symptoms are also likely to occur due to the weak pharyngeal muscles. Delayed swallow initiation, incomplete bolus formation, weak chew, fatigue while eating, choking on food by mouth, aspiration, and pneumonia are all possible symptoms the patient could experience. This inability to swallow efficiently compared to their once normal swallow could impact the patient's overall view of their quality of life. This is important to keep in mind when counseling and educating a patient and their family. You must remind them that you are there to serve the patient and provide them with recommendations that will help them achieve the best next level of possible care and provide them with recommendations based on their individual needs. The neuromotor and speech impairments can also be present in an OPMD patient. The neuromotor impairments include slow diachokinesis rate, facial weakness, which can slow the coordination of the articulators, and speech impairments that may include articulatory errors, segment duration measures, spectral moments, vowel spacing, frequency, intensity, and voice quality. Although the speech impairments may not be as detrimental to the patient's health as the dysphagia symptoms, it is still important to be aware of these deficits so we, as the SLPs, know the patient's communicative strengths and weaknesses, as these characteristics can be variable from one OPMD patient to another. Before consulting the patient, it is important to review their chart before even walking in the room. On the chart, you can see the patient's symptoms, medical history, current medication use, past referrals, and any previous diagnoses. It's important to know this information to get a comprehensive picture of the patient before even making your own observations. The chart review should be a collaborative effort with everyone on the medical team. It's also important to learn psychosocial history, other consultant findings, and conduct interviews with the patient and the family in order to answer the referral question. This way, you are assessing and treating the patient as an individual and not based on their impairments. After patient family interviews and initial assessment, a clinical bedside evaluation can take place. This evaluation is where an oral peripheral examination can take place, where you can take a closer look at the possible affected structures and their functions. Varied tasks, dependent on the patient's current status, could also be administered. Remember, you cannot administer these tasks if the patient is intubated, unresponsive, or lethargic. These assessment tasks for an OPMD patient could include swallowing, speech, and orientation. Orientation would be assessed because, according to the literature, some patients may be experiencing delirium or confusion, so it is important to gather this information. After learning your assessment information, if the patient has not previously received an OPMD diagnosis, a blood test or muscle biopsy should be gathered by the physician or nurse to check for gene abnormalities. The healthcare team will be able to discuss and conclude if an OPMD diagnosis is warranted. If the patient came into the acute care setting with an already confirmed OPMD diagnosis, then it is our job to routinely check their swallowing and speech-related symptoms of concern to make certain we manage their condition productively. Applying the ACM means including the patient and their family as the center of care. On the last slide, we talked about service delivery methods, and on this slide, we will get further into why it is important to abide by the patient and their family's wishes. We want the family to be realistic about change and engaged. Therefore, we must inform them on our observations. We must educate the family and patient that OPMD is a progressive condition, but we can assure them that we, as the SLP, will do everything we can to increase the patient's comfortability level and facilitate change. As far as safety is concerned, us as the SLPs have to ask ourselves if it is safe to feed this patient by mouth. Are they receiving adequate hydration and nutrition? These questions are important to keep in mind to make sure we are making the appropriate assessment decisions for the OPMD client. For the psychosocial aspect of the ACM, the SLP should consider how involved is the family. What is the family dynamic like? What is their relationship with the patient? Also, how is the family handling their loved one's diagnosis? Often the OPMD patient is diagnosed with onset of symptoms around age 40 to 60 years old. This means that the diagnosis is not only affecting the patient, but the family as well, and possibly their sense of normalcy. The main treatment for OPMD is surgical, non-surgical, or compensatory and direct strategy based. We can monitor, counsel, and give brief therapy recommendations and modifications in the acute care setting due to time-limiting constraints. Referrals for the patient to receive surgical and non-surgical treatment should be conducted by the medical team in order to ensure that the patient is receiving the most effective form of treatment for their case. To summarize, OPMD is a congenital condition that, although rare, has psychological, psychosocial, swallowing, and speech impairments on the patients it affects. Dysphagia and ptosis are the main concerns for healthcare workers, while dysphagia, pharyngeal weakness, and speech impairments are the main concerns of SLPs. It's also important to keep in mind that diagnosis must be confirmed by genetic testing after referral and thorough patient assessment. The most optimal treatment for patients with OPMD in the ACM is patient and family counseling, management of symptoms, and compensatory modifications for speech and swallowing deficits. And these are my references. I hope you learned something about OPMD from this presentation. Thank you.